I want to thank Jennifer for that wonderful, inspiring story. I want to ask Anita to come back, and I want, if we could put the last slide back up, because I think it was a great slide. Oh, there we go. And now is the time to really have a discussion. We have about 20 minutes.
Can I ask you, though, is the food here, doesn't it smell like food a little bit?
No, they're supposed to give me the high-fi. Yeah.
Okay.
Not yet, not yet. Good question, though. Breakfast is the most important meal. So this slide, I think, has really made me think a lot. So thank you for the slide. And so I guess let me start the questioning by saying that you've had a lot of, it was a great talk, and you touched on so much in a very little time, I know. So thank you for doing that. But you've had a lot of experience in spread, scale, and sustainability. So one general question I have is, in terms of accelerators, what are the accelerators that are really critical to achieving all three, spread, scale, and sustainability? You talked some about the challenges, the trade-offs, but what do you think are the accelerators? How do we not do those last three? And I was really struck by that, because I think we're doing it. We're doing the last three, and we need to be doing the first three.
Well, thanks for the question, and let me answer it by, if you bear with me, just going back to an early slide here. You know this. One of the things that strikes me as a management scholar, as a professor who studied companies most of my career, strikes me about health and being part of this global health conversation, is that we don't know what we're seeking to achieve frequently. We have this idea that we want to create health and well-being, but it's not entirely clear what that is. When I reflect on my own experiences of health, often they don't have as much to do with the administration of healthcare by a doctor to me in an office. They have more to do with my experience of my family and the children of my life, and effective experiences in personal choices that have led to positive health outcomes for me, such as the decision not to smoke. So how do we cultivate those kinds of behavioral outcomes in communities? That question is a slightly different question than the question of, how can we run what we do more effectively? We know we can't afford the health system that we have. We spend about $10,000 per person per year in the United States on health care. We spend about $6,600 or so, depends on how you count, but $6,600 or so in Canada per capita per year on health care. Most people in the world don't make that much money annually. They don't make $10,000 per person per year. Average per capita income in the world is at about that level. So exporting and expanding the system we have is not going to work. We have to innovate out of the health system that we have. So what I'm really most excited about is trying to cultivate resilience more cost-effectively and with higher quality at the same time. Most of our healthcare institutions are not designed to prevent illness. If you see a clinic and no one's going to the clinic, is that clinic successful or failing? Tuberculosis clinic in Kenya, nobody's there. How do we measure effectively whether that clinic has been so effective that nobody has tuberculosis in that community? I was talking with one of my friends who's a global health doctor some years ago, about 10 years ago now, Paul Farmer, who's a global health doctor, and he said to me, Anita, if we put in a clinic that says tuberculosis clinic in, any place, Rwanda, no one goes because of the stigma associated and the fear associated with being diagnosed with tuberculosis. Nobody wants to be diagnosed with. We have to go in a very different way into the community, and what we've learned is that by going in a different way, we can save a lot of money by not building a clinic that no one will go to, through more targeted interventions where the community starts to take responsibility for its own tuberculosis diagnosis, and we can treat more patients more cost effectively and more medically effectively with the resources that we have over time. We need to redesign our health system to achieve better outcomes at lower cost. And here's my list of where the high leverage points are.
Thank you again for your talk. Dave Kindig, University of Wisconsin, and co-chair of the roundtable. On the last slide that we had up there, you have measurement as one of the key items, but then you also warn us against, what is it, untethered data mining. So would you say something about where measurement can be helpful in terms of spreading and scaling and in terms of fostering change?
What an honor for me to get a question from you as the author of the definition of population health.
Along with Greg Stoddard, a distinguished Canadian health economist.
Thank you so much, and thank you for inviting me and for this question. You know, there's a lot to say about data mining. You all know that mobile telephony, the internet, provides us with tons of data that are ripe for analysis. And as someone who's a little bit of an introvert and more comfortable behind a computer than, talking with with you today, for example, by nature, my tremendous inclination is just to go swimming in data and trying to figure out what we can do to try to, make somebody's life better. But that's really dangerous. You know, it invades people's privacy, the tremendous opportunity is being wasted when we don't think more deeply about what we're trying to accomplish and what the question is that we're taking to the data before we begin. There are also problems associated with this data because of its nature as a panel. Much of these data sets are not very deep in terms of their intertemporal characteristics. We don't have a big time series. You get cross-sections here. You get changes in the panel over time that have more to do with access to mobile telephony and internet by users than they do with coverage over time of individuals. So what we know is that you have to be very thoughtful about what the questions are that you're seeking to answer. Also keeps you very focused in the rearview mirror, you know. It's like looking in the rearview mirror, but only at the car behind you and trying to drive forward effectively.
George?
So does this work? Yeah, great. So in my opening comments, I revealed some of my perhaps inappropriate early thinking about this topic before being exposed to this excellent presentation. Thank you for it. I'm impressed with the notion that a platform is necessary for scalability. And I'm also impressed that, at least in my thinking, and maybe I'm not thinking about this appropriately, is that in order to achieve our objectives as a roundtable in terms of better health, that we need not only to scale programs and interventions and management in terms of how our organizations work, but ideas, beliefs, and values. So in terms of that notion of a platform for scalability, how might we think about that? What lesson might we take from your experience and your expertise in terms of thinking about a platform or a concept for that? And maybe this is an inappropriate question. I'm not an expert, but
I'm grateful for it. Ideas, beliefs, and values are the ultimate platforms. The ultimate platforms. The definition of scale from economics is that by growing, by adding volume to a particular activity or group of activities, that you achieve more effective results for the marginal person that's brought into the fold, as well as for everybody else in the fold by virtue of the growth. Let me give you an example. Let me give you an example here. Let's imagine, George, that you and I were the first two people to use Facebook and that nobody else was on Facebook. You know, it'd be valuable, I'm sure, to me and hopefully to you, but not nearly as valuable to the two of us as when everyone else in the room signs up for a Facebook account. The platform associated with Facebook creates an economy of scale. The cost of running Facebook in this example, in this simplified example, is relatively constant. You got to set up the fixed costs with the software and put it on a server, but and there's no incremental cost in this example associated with everybody else joining Facebook. So the cost per user is going down, including to you and me as the first 2 users. And the platform is more effective, right? Because you and I enjoy Facebook more by virtue of the fact that there's more people on it. That's because Facebook is scalable. I'm using platform here in a very liberal sense to include any approach by which using more of the approach or the belief or the value or the tobacco control software in Ontario, more users may make the support network that's available to me as a smoker in Ontario better, not worse. If I sign on, and there's many of you that are signing on as well, I get more support, more engagement, more friends that I can go for a coffee with instead of having a cigarette than if there's fewer people who are signed up on the platform, right? Ideas are the ultimate in platforms, beliefs and values, because there's no cost to setting up the software. Do you know what I mean? You're getting started by cultivating beliefs, getting started at zero fixed costs, and then building marginal costs that are also zero on top of that, and hopefully creating a pandemic of health as a result. We've got both microphones have speakers at them. I think you might have been first.
Thank you. Thank you, Nina. Terry Allen from Cobb County and Greater Cleveland Health Department, and also from the National Association of County and City Health Officials. I'll go closer. Is this better?
It is,
All right,
indeed.
thanks.
From Cleveland.
Yes,
Terry
thank
from
you.
Cleveland.
Right, thanks. I was very interested in your use of resilience in the context of resilience from a public health standpoint. My familiarity has been around resilience as it relates to emergency preparedness.
Yes, of
And,
course.
you know, I heard some speakers, for instance, from Israel that have talked about that elasticity of populations and the ability to bounce back quickly. In the context of resilience, in terms of resources on building and cultivating resilience, can you talk a little bit about that? Because I think that's very interesting in the way that you're describing it here.
So let me just say give a few examples of the way I think about population resilience. And Terry, perhaps you have some as well that could be in the mix. You know, communication systems between different hospitals in a city like Cleveland that allow them to coordinate care in the face of a public health disaster. Systems for coordinating the payment for care so that we can easily transfer patients between hospitals when a specialist is available at one hospital that isn't available in another hospital. Working together in communities so that if we find a particular, let's say, chapter of AA that has lost its meeting space in a church because a church has to close down in a particular area, that we can get community resources activated so that that chapter quickly finds an alternative place to meet so that chapter doesn't have to close and its members are at risk of then not having the support that they need. So whatever it takes in Cleveland to get the existing systems to work together more effectively is a first step toward resilience. Disaster preparedness, disaster response, but then disseminate it into all the different kinds of activities that cultivate health in that community. And then on top of that, starting to look at social determinants of health more deeply, right? So making sure that the sanitation system works, making sure that where they're needed, that there are informal and automatic aid agreements between fire departments so that different fire departments in the greater Cleveland area can come to each other's aid when there's a need for them. You know, things like that may be one order of magnitude away from what we conventionally think of as part of the healthcare system, but that have tremendous impact on exactly how citizens of Cleveland may experience health. I was also tremendously moved by what I saw here overnight in New York City, which I experienced as a very healthy response to the failure of the indictment yesterday on the Staten Island chokehold episode. You know, the indictment came out, the grand jury's decision came out last night, and we saw Mayor de Blasio, as well as leaders from around the city on television yesterday, asking for nonviolent protests. For me, that's resilience. That's the mayor who was so compelling, so engaged, so believable, so personally persuasive in his remarks that what we had overnight was many protests around the city, but as far as I could tell overnight, no violence, no episodes of violence. And that kind of leadership for me is part of resilience as well. Thank you.
Great talk, Anita. Thank you.
Thank you, Sal.
You're stimulating thoughts in me that are different from my area of expertise. I'm with the Division of Public Health and Tobacco Prevention and Control. But in your talking about treatment and particularly franchising collaboration, it made me think of a struggle that we're having in North Carolina, where behavioral health is over here and physical health is over here, and sometimes the two groups who have skills that need each other aren't working together. In my area of tobacco control, for example, behavioral health clinics have seen tobacco as a lesser problem because it's a legal drug, where they need to treat alcohol and other drug abuse, illegal drug abuse. But they're successful in that, and people go on to die of tobacco-related illnesses. They have the skills. They just think it's the medical people's problems. And there are different payer mechanisms in both parts. So we're working on bringing together behavioral health and medical health folks in this kind of franchising collaboration. And I wanted to get your thoughts about that and enter that into the conversation that we're having here today. Thanks.
Thank you very much, Sally. Everything that I encounter emphasizes the importance of behavioral analysis and interventions in behavioral health. Mental health services are one component of this. Effective tobacco control programs are one component of this. But only one component, as our conversation on the shuttle this morning illustrated here. We have to advocate for patients on patients' terms and really understand what's going on in patients' lives that lead them to make choices that may have long-term consequences and affect the delivery of what you call physical health, in a medicalized sense over time. One may I quote you, we had this great talk this morning. You were pointing to the importance of new research that shows the long-term health consequences for a child and eventually a life, really, as that child grows, of the mother's smoking or exposure to secondhand smoke early in pregnancy. Cultivating awareness of that. If I am a smoker and I see that you're pregnant, or you tell me you're my friend and you tell me that you're pregnant, if I'm aware of that kind of consequence, I may decide not to smoke in your presence. And just cultivating awareness, selling health, selling population health, advancing kind of a mutual commitment to our long-term health begins with public knowledge about the health consequences of different behavior and runs all the way through early diagnosis, supporting patients that have adverse diagnoses, getting patients' families involved, providing support where it's needed, all the way through to elder care and late-stage support for patients. As I mentioned, I was at the University of Vermont the other day, and there was an elderly gentleman who was in a talk that I was giving about the consequences of the aging of population, and I asked everybody in the room to shout out how they'd like to die in the end, what their number was and how they would like to die. And he said that he would like to die at age 95 of a gunshot wound from a jealous lover, this guy. Trying to think about how to support, through behavioral interventions, people through their entire lives is a huge underdeveloped opportunity. I'm so grateful for the question. Thank you.
So we have time for 2 quick questions, and then we'll go to a break because the food is here.
Oh, right on.
So 2 quick
Maybe
questions.
we should go to a break right now.
Mark Goravich from the Department of Population Health at NYU. In terms of framing scaling and spread in the context of resilience, just to drill down on that a tiny bit, resilience implies, even from the public health world, that one is springing back. And how does that jibe with prevention? So how do you incorporate, because how do you square resilience, a focus on resilience with a focus on prevention, which seems to be a little bit different?
As you know, prevention is the headline on my, on resilience. Here's how I think about it. We're all constantly challenged by health problems. I mean, I'm going to walk out of this building and the traffic on 3rd Avenue is going to present a health challenge to me. My ability to be aware of the problems that I may encounter on 3rd Avenue is partly a result of the quality of the breakfast that's sitting outside. So I think of it as, you see what I'm saying? I'm thinking of this as not episodic, but a continual process. Is that helpful? Thank you.
Thank you.
Good. I'm trying to be short, can you tell?
yeah.
You know?
Sandy Magnin from the Institute for Clinical Systems Improvement. So I've heard you speak to things that remind me of building trust and relationships, as you've talked about spread, scaling, and sustaining. How do we pay attention to that, or what's your experience about doing that versus doing the innovation and doing the measurement, et cetera? Where's that balance there, and how do you see us going about that?
We have a lot of research in management on trust and relationships and the connection between trust and relationships and measurement. Let me just say a few things that I hope are useful to you in the next day and a half for your deliberations. What we know is that you and I together as a team can achieve much more than each of us can achieve individually. So trust and relationships are crucial. Getting consummate performance from us as a team, depends not on measuring, nickeling and diming us in terms of measurement. We know more or less that in order to get us, if you nickel and dime us on every little action that we do, you get perfunctory performance to the contract instead of consummate performance to what we can ultimately achieve together. You're going to kill our motivation, even if we do trust each other, you're going to kill our motivation to try to over-deliver, if you are squeezing us on every single thing that we do and micromanaging us. Okay, so how do we achieve consummate performance? It's by measuring us, and it can't just be simple measures. Otherwise, if you just measure us, we need a dashboard here. It can't be just one thing that you try to compel us to do. It has to be a sophisticated dashboard of objectives. Our best research suggests that that dashboard has to be built collaboratively with us in a way that we can drive exceptions, we can have conversations about things that are important, but still gives us guidelines for what to do that's effectively. We essentially need rules of the road. I mean this heavily analogously. You know, some of us drove here. When you go out and drive, you know how you're sort of on autopilot when you drive? Hopefully this has become routine enough. We know routine is crucial to effectiveness, right? That you have to be habituated. You can't be, one reason that teenage drivers are so dangerous is because they're thinking about every single thing. You and I, who have been driving for decades, get into our cars and we can devote our attention to exceptions, because it's automatic to us that we're going to turn the blinker on when we get to a stop sign, or that, if the speed limit says 55, we're not going to go above 60, right? So getting us those rules of the road, trying to create traffic rules that allow us to deal with exceptions effectively is how the right way for me to think about the relationship between trust and relationships and measurement.
Thank you so much, Anita. That was just terrific. It's a great way to start. Let me, so yes, thank you again. I want to do a couple housekeeping things. First, in my opening comments, I wanted to make sure that we thank Darla Thompson for her great work in supporting us on pulling this together. I don't know if you noticed that on the bus it said Darla Thompson, so we're all on the Darla Thompson bus. So Darla, thank you. Let me also introduce our next session, which will be out there. I'm going to ask the facilitators to come in for 1 second so I can introduce them. And there's Darla. Come on in real quick. So what we're going to do is for our audience on the web and through the webcast, we are going to break till 10:30. And in that time, we're going to enjoy the breakfast and do a few minutes, let people kind of enjoy the breakfast a little bit, but then we're really going to move into the engagement, because I think we can do that while we're having our breakfast. So we have two people here today from Arena Stage in DC. And let me introduce them quickly. One is Ashley Foreman, who is the Director of Education at Arena Stage. She's in her 12th season in the Community Engagement Department and is responsible for the design and the development of Voices of Now. And then we also have Fareed Mostufo, who is Community and Training Programs Manager at Arena Stage. He's in his 4th season, working as Director in Education in the Community Engagement Department. And Darla and I had the pleasure of being a part of their facilitated activity at a different IOM session, and we thought it'd be great and really perfect to do it for this session and to really help us make sense out of what we've just heard with respect to spread, scale, and sustainability. And so at this point, I'm going to ask the folks in the audience to move out to the other room where there's breakfast and where we'll do our facilitated discussion. All right, thank you.